repairs. So we start our first presentations, that is critical view of MPU. In order to do a proper repair, knowing the anatomy is of crucial importance. So when we approach a patient for a hernia, the primary goal will be the prevention of recurrence always. That's what we think. As a surgeon, we always think our primary goal will be the prevention of recurrence with low morbidity, faster recovery, and improved function, and with cost effective methods. But the literature says a successful hernia surgery depends upon three factors. One is the anatomy, the other one is the mesh biomechanics, and surgeon's experience plays a crucial role. And of the three, among the three, I always tell the anatomy is the base for the surgeon because he has to understand these things. Then only he can improve his technique and properly can be applied to the patients for a proper outcome. So, coming to the introduction, in-depth knowledge of groin anatomy is essential for the successful inguinal hernia operation that we know. That's why Bessini tried to dig this anatomy almost in 1884 itself. But you can see from 1884 to 1990s, in almost 100 years, no one has explored the posterior anatomy properly. That's why little in its paper, he is reported the operating surgeon knows little of the posterior wall of the inguinal canal, so well is it hidden from his view. In early 90s, the laparoscopic approaches for the inguinal canal has emerged that we all know. The posterior anatomy of the groin remained poorly understood till now on that period. So the basic anatomical principles of laparoscopic herniorrhaphy were first described by Spa in 1991. He coined the term triangle of doom. Coming to the MPO, that is myopectineal orifice. The term MPO means that is coined by Henry Fruchard, which refers to a distinct area of weakness in the pelvic region. We know all the groin hernia emerge through this except this obturator. You can see this both direct, indirect, and the femoral hernia emerge through this. This weakness area allows the passage of blood vessels, nerves, lymphatics, vas deferens, muscles, tendons, and fascia. You can see the three hernias, that is the direct, indirect femoral hernia, the triple area that is known as called the MPU. The MPO boundaries. Medially, it is guarded by the lateral border of the rectus muscle, laterally by iliopsoas muscle, inferiorly by the bony margin of pelvis, and superiorly the transversalis fascia and the internal oblique. So you can see this whole area has to be properly covered with the mesh in order to do a successful hernia surgery. This can't be done in an open repair. The epigastric vessels divide the myopectineal orifice of Fruchard into a medial and lateral compartment. The inguinal ligament divides it into anterior and posterior. That is a suprainguinal region and subinguinal region. So you can put a cross. So the vessels divides into lateral and medial. The inguinal ligament divides into anterior and posterior. Coming to the signature triangles. So you have to know all these triangles when you do a proper repair. That is the triangle of doom, triangle of pain. Reinhard Bettner used the term trapezoid of disaster, particularly for the triangle of pain and corona matis. These three things, that is the triangle of doom, triangle of pain, corona matis, you have to get a knowledge to do a successful laparoscopic hernia surgery. So corona matis. This is an arterial anastomosis between the obturator and the inferior epigastric arteries with the ectopic obturator artery. Almost 20 to 30% of the people will have this. Several variants of anastomosic vascular branches exist, of which one of the very important thing is circulation of Bendamine. That is composed of suprapubic, retropubic, deep inferior epigastric, and rectitial veins. These vessels and the underlying pubic bone are covered by a very thin membrane that should not be disturbed. That is the main carrying point in this slide. Corona matis, you should not disturb it. There will be a layer over that. Never peel that layer, otherwise it tend to bleed. You can see in this video. So after we are trying to do the dissection here. we are exploring the arterial anastomosis. That is an abnormal ectopic obturator artery between its communication from the obturator and the inferior epigastric. You can see in a medial dissection, we are exposing things for you. You can see the inferior epigastric and the aberrant artery, obturator foramen, obturator artery, and the external ilia. You can see these communications of plexus. And you can see in this video, that is the area triangle of Doom that is in between the vessels and the vas. The external iliac artery, GFN, and deep circumflex iliac vein will be the content of this triangle of Doom. Lateral to these vessels is a triangle of pain. You can see the dulux fascia. The dulux fascia has to be intact. You can see the content of a triangle of pain. That is GFN, LFCN, femoral nerve. You can see these are the potential nerves that can play a part in your dissection. So that's why give almost importance to all the layers here, because you have to travel through the layers. The layer is already there. Don't try to create any layers here. You can see the ectopic artery, inferior epigastric, anastomotic branches. You can see never disturb that area. You can see a thin membrane here. This thin membrane has to be intact at all the scenarios to avoid the bleeding. Never disturb these thin membrane over the bone. You can see here the obturator nerve, inferior epigastric, and aberrant obturator artery. Coming to the nerve topography. See, after giving importance to the vessels, the next thing what we are going to give importance is the nerve. Rosner was the first to describe the inguinal neuroanatomy in 1994, roughly delineating the nerves along its course. So we know that almost 6 nerves are of interest in doing a groin hernia repair. That is your iliohypogastric, ilioinguinal, femoral, and the genitofemoral nerve, lateral femoral cutaneous nerve, and I am including obturator nerve also, because sometimes it is very difficult to go and see and explore that particular area. But in some of the patients we have seen, these injuries can happen. The femoral nerve is generally well protected by the psoas tendon. So injuring a femoral nerve during the laparoscopic hernia repair is almost very difficult. And obturator nerve, it is anecdotal because it is well hidden. Never go and explore that area. And your ilio, that is IHN and IAN, ilioinguinal, iliohypogastric, both are travel into the inguinal box, which is superficial to the inguinal ring. So injuring to these nerves also very rare. So coming on to this, we have only 2 nerves of interest. According to Renipold, he told the GFN and the lateral femoral cutaneous nerve is more even dangerous. That even these are the nerves were claimed to be typically injured doing a laparoscopic hernia repairs. So now we jump to our main topic, that is Day's modifications of MPO. These MPOs as defined because the repair may be a TEP or TAPP, may be a lap or robo. These areas has to be properly cleared before placing a mesh. Regardless of the approach, regardless of the technique, the proper area of exposure is very important in order to keep a mesh. Thereby, it limits the recurrence. He devised 9 steps. It's almost the first step. Everything is just medial to the inferior epigastric. The first step involves the dissection of the pubic tubercle and the ligament. The second, you have to dissect the Hasselbalch triangle, that is above the Coopers. You have to dissect that direct area, remove any unusual fat in that area. The third step, just come down, that is below the Coopers, dissect at least 2 centimeters in the space of Retzius, so to accommodate the mesh. And the fourth is to dissect the femoral space between the Cooper's ligament and the iliac vessels. So everything will be medial to the inferior epigastric here, these 4 steps. This is what we are going to see in this video. You can see we are exposing the Coopers. You can see the iliac vein here. So the medially the dissection has to be carried out. This is the femoral area that has been cleared out, and the direct area, the content has reduced. You can see the Hasselbalch triangle here, which is bounded by these boundaries, and you can see the triangle of Doom, which is guarded by the vas and the gonadal vessels. and the triangle of pain lateral to that. So this is the first 4 step, dissect that area. So coming on to the 5th step is to dissect the indirect sac, and the peritoneum has to come down. The step 6, you have to look for any cord lipomas, and 7th step, that lateral dissection up to the ASIS to accommodate the lateral, that is a space of Bogros. You can see in this video, this is the femoral area. This is a step 4. You can see which is bounded by the lacunar and the medially. Posteriorly, the anatomy differs. The femoral area, you can see the direct and the femoral area. This is the 4th step. So up to 2 centimeter, you have to dissect to accommodate the mesh. So the paratalization. So after delineating the space of Bogros, the next step will be handling the peritoneum. You have to bring down the peritoneum. If it is a direct hernia only, there is no indirect sac. You have to bring down the peritoneum down. You can see the abductor nerve there. So the dissection has to be carried out meticulously in order to avoid any injuries. So once you bring down the peritoneum, then the triangle will be formed. So the paratalization has to be done. And I look for any lipomas, that is any indirect, any lipomas, it has to be removed, because it will produce any false symptoms. The patient will present again with any inguinal hernia symptom. So always try to remove the cord lipomas in order to carry out a successful hernia surgery. So coming to the 8th step, the mesh is placed appropriately. The defects has to be covered in all aspects. And step 9 is fixation of the mesh. What we routinely use is fixed to the Coopers, but literature tells you can fix it 3 points, except below the IPT you can fix wherever you want, because in case of a larger hernias, sometimes you may need a larger mesh, not the conventional mesh. You can see here in the step 9, after the step 9, we have included one more step. That is, in case of a larger hernias, larger groin hernias, or a larger direct hernias, that needs to be plicated. In case of an indirect hernia, you can see here, this area needs to be closed because it is almost a large indirect hernia. You can't keep a mesh like that without closing the defect, because more than 4 centimeter, sometimes parachuting of the mesh will happen, the immediate recurrence like symptoms. So what we do, we just approximate the conjoint tendon to the IPT. So the bite should not be too much deep. As I already told you, the nerve will be at risk. That's why it has to be done superficially, only to give a flat surface for the mesh. This area will not give any strength to that particular area. Only the mesh has to sit, the area has to be flat for the better imbibition. We always keep a drain in case of a larger inguinal hernias. So in case of indirect inguinal hernia, we always close the ring if the ring is more than 4 centimeters. And in case of a direct hernia, it is easy to do, but you can see when you see a large direct hernia in the groin, you can see the surgeon's face. My face will be like, I will not be happy, because handling these large direct hernias, maybe doing is easy, but keeping the mesh in this particular area is tough. So in order to keep a flat mesh, what we do, we always plicate this. So like this, we use a barbed suture, because after the evolving of the barbed sutures these last 3-4 years, this plication is very easy. You can plicate this to the rectus muscle or to the Coopers. So once you do the plication on both the sides, now you can see the area is flat. Now you can be able to keep a mesh and suture it. So finally, the take home message, MPO, the 3 hernia sites, that is the direct, indirect and the femoral area, has to be covered with the polypropylene mesh and to be fixed. We always do the fixation. Thank you. On the view. Can't share screen over there.
Just like the video.
Share it. Sir, hopefully the first lecture is over. We move on to the second set of lectures, sir, which is Dr. Dinesh is there to ready with the TEP. how we evolved from the basic midline technique to triangulation technique, and what are the steps to do it easily. The Dr. Pallives are taking how we improved. So Dr. Dinesh will explain those steps. So after this lecture, we'll first move on to the first live surgery, that is TEP, followed by a robotic TEP. The two cases will be on the live, sir. Moving on to Dinesh, sir. Now I move on to Dinesh. Dinesh, you can start. Dinesh, you can
Thank you,
start.
sir. That was a wonderful explanation about the MPO. Now we'll move on to the TEP, what surgical steps, how we do it in Palnivelu search technique. So for TEP, there are multiple facial layers which we should be understanding first. So for following up the facial layers, which we'll be seeing in the upcoming short videos. First is the rectocial fascia, which is nothing but the posterior epimysium of the rectus abdominis muscle, and followed by the complete PRS and the incomplete long posterior rectus sheath, and the transversalis fascia, which has a two component, anterior and posterior layer or lamina, and the urogenital fascia, which will be covering the bladder and the preperitoneal fascia. So, what is the goal of a TEP? The goal of TEP is to completely dissect the myopectinal orifice of Fruchan, which should expose all the three areas plus the fourth area, obturator area. So, indirect, direct, and femoral area should be exposed, followed by obturator area if obturator hernia is there. So, what are the approaches for DEP? Based on the evaluation, there is for two methods which has been followed by Dulux and McKernan, and followed by our Palni-Velusas technique, which I will be seeing in the upcoming slides. And DAYS modification is nothing but putting an enhanced view TEP, putting a port just above the umbilicus cranially. Coming to the trocar placement, in Dulux and McKernan's technique, trocar placement will be in the midline. So the problem with midline is a parallel port. There will not be no triangulation, so that azimuth angle and manipulation angle will not be there. It's not ideal for suturing, and frequently have to change position for the sides in case of bilateral hernia. Coming to the Palnivelus technique, the 10 mm trocar is placed subumbilically, followed by at both the pararectus level, at the level of medial to the linea semillunaris, we will be placing the two 5 mm trocars, which will be 1 to 1.5 centimeter below the midline port. So in this way, we will be maintaining both the azimuth angle and manipulation angle, and there is no need for change of position. So this is the position. Patient will be in Trendelenburg position with 15 to 20 degree of tilt, and surgeon will be standing towards the right shoulder of the patient, and camera surgeon will be standing towards the left shoulder. Monitor will be at the foot end of the patient. There is no need to change the position. We can operate bilaterally with comfortably on bilaterals on both sides. For a hernia, initial port placement, there is a special retractor which is devised by Dr. Palnivelu sir, which is Dr. Palnivelu's hernia retractor, which has a curved tip, curved edges over this thing, so that visualization will be easier. This is the first step, placing a subumbilical first port. 1.5 centimeter subumbilical incision is made, and the subcutaneous tissue is retracted. Anterior rectus sheath, right side anterior rectus sheath is incised transversely, and using Kelly's forceps, we are dissecting the space and trying to hook out the rectus abdominis muscle laterally, so that PRS will come under vision. You can see the PRS now, and the trocar is placed into the PRS. So this is a posterior rectus sheath approach. Avoid the linea alba to avoid the inadvertent injury to and entering into the peritoneum. Next is before inflating the Nemo, just to see whether the muscle is anteriorly seen and posterior rectus sheath is seen below. Then start inflating. Whereas the first fascia is rectocial fascia, which will be the posterior epimysium of the rectus abdominis muscle. So ideally, the right plane is going one plane below, leaving the fascia towards the rectus muscle. So we prefer to go with the telescopic dissection rather than balloon dissection, because this balloon dissection might cause sharing of the vascular supply and bleeding, and it will make the field bloody, and further dissection will be difficult. Whereas in telescopic dissection, you can avoid the vessels under vision and dissect the preperitoneal space. Once the dissection is completed, inferior epigastric one second. Once the dissection is completed, you can see the inferior epigastric vessel hanging over the roof, which will be covered by the fascia transversalis, which should not be disturbed. And you can see the direct sac over there. Next comes this second trocar placement, which will be placed on the right pararectus level, just at the level of arcuate line or 1 centimeter below the midline umbilical port, subumbilical port. Next comes the crossover. Crossover we can do either with a hook or scissors, which is on surgeon's comfort. And crossing over will be initially doing just above the preperitoneal pad of fat to avoid inadvertent injury to the peritoneum, so that the peritoneal rent will make the dissection difficult further. So coming to the crossover, the PRS attachment to the linea alba is divided in the midline just 1 or 2 mm below the linea alba. So that we will be seeing the preperitoneal midline fat. This is the preperitoneal midline, where your point of dissection is going to be, this is the PRS and above is the linea alba. This is the preperitoneal plane, where we are going to dissect just close to the muscle and the anterior abdominal wall, taking down the preperitoneal pad of fat. You can see the left side PRS now. Once it is taken down, peritoneum will be below. So to avoid the injury to the peritoneum, what we used to do is we will be cutting, either we can cut the PRS at that point and take it down along with the peritoneum before placing the third port, or you can try to dissect in between the plane and take it down. Once this retrorectus place is dissected, you can see you can appreciate the arcuate line here. You have dissected 1 or 2 centimeter above the arcuate line for the third port placement. The third port, which is the left pararectus, at the level of left pararectus, has been inserted. Next, we will go for the space of Retzius dissection. Here we are keeping the midline fat in situ without dissecting. We are dissecting on either side of the midline fat and seeing the bone on either side first. You're able to see the pubic bone over there on the right side, followed by which the same dissection is continued on the left side until the bone is visualized. Once this is done, now you can cut the midline facial plane, thereby avoiding the bladder injury. And the section has to be stay as close as possible to the anterior abdominal wall. As you go caudally, try to stay away, stay at anteriorly, so that we will be not injuring the prevesical plexus. So the space of Retzius has been dissected. Next, we'll go for the lateral space dissection. This is a fascia transversus attachment. Sorry. This is a fascia transversus attachment lateral to the inferior epigastric vessel, which we are going to divide to enter into the space of Bogros. And this point will be the weakest point of fascia transversus, close to the deep ring, which will be easy with the plane where we will initially dissect and create the space. Just by giving traction and counter traction, you can open that plane so that we can easily enter into the space of Bogros. You can see the peritoneum and indirect sac below. Now what we do is, this is the lateral edge of the peritoneum, which is forming the indirect sac. This is the transversus fascia, which we are going to divide to enter into the lateral space. Judicial amount of cautery should be applied, and layer by layer, not too deep, to avoid injury to the peritoneum at this dissection. This dissection is continued cranially up to the arcuate line. You can now able to see the transversal sling fibers, which has to be divided during indirect sac dissection. Otherwise, indirect sac dissection will be difficult and content will not get reduced. This transverse link fiber forms an anterior and posterior limb, which will be divided at this level. Initially, we'll see about indirect direct sac dissection, which will be easy. Direct sac will be nothing but thinned out fascia transverses, which forms the pseudosac. You're able to see the differentiation. The preperitoneal pad is being reduced, and this is the limit of pseudosac. For pseudosac reduction, in direct hernia, there no need of energy device to divide cautery. Since it has a avascular plane in between the content and the sac, just we can reduce by traction and counter traction. This is a case of large direct hernia where you can see the sac. Now we have to placate. In such case of large direct hernia, as Dr. Bharat sir told, we have to placate the sac. Otherwise, there will be a lacunae where the mesh might migrate and the mesh imbibition will not happen. So initially we take a bite of the corpus ligament, and before taking bite of the corpus ligament, any accessory operator vessel has to be coagulated with bipolar, because during dissection it will not bleed due to the pressure. Some patient might have a reactionary hemorrhage later, so ideally it has to be coagulated before taking a bite of the corpus ligament. Here we are using a monofilament proline, 10 proline to placate. Either we can use barb suture. That also depends upon the surgeon's preference. We have taken 2 bites of the corpus ligament to anchor. Now the sac is completely placated. You can see the difference between before placation and after placation. In case of indirect sac, the dissection, first the adequate lateral space has to be dissected. Then only you will have adequate space on the lateral side to identify the lateral edge of the sac, indirect sac, and divide. And followed by which the sling fibers has to be cut. Adequate traction is also important. You have to separate the sac from cord structures carefully without damaging the cord structures. This is a video of indirect sac dissection. Indirect sac dissection usually starts with anterior and followed by lateral dissection, followed by medial, and finally the posterior dissection once the fundus of the sac is being seen. The left hand adequate traction should be maintained, and this fat attachment should be coagulated minimally with the judicious amount of cautery, and then it has to be slowly taken down. You can see the lower edge of the peritoneum. Here you can see the peritoneum edge and the sling fibers. We can visualize. Once after visualizing, we can cut the sling fibers medially so that the vast difference will come into the field. You are able to appreciate the vas now. And after complete paratalization, you will be able to see the medial umbilical ligament and the vas turning medially. This is your lower limit of dissection. We have to take down the peritoneum about 1 to 2 centimeter below the pubic ramus for adequate mesh coverage and to prevent the migration of mesh during bladder filling of the bladder. You are seeing the operator now, which will be the inferior limit of dissection. Let's have a look at the complete sac, indirect sac dissection. So now we are seeing the transverse facial attachment lateral to the inferior epigastric vessel, which is here. So we'll be cutting using a hook. As I said, cautery has to be applied minimally. Just cut the anterior transverse fascia alone. Now once it is cut, you can hook the loose irregular tissue and divide it. You can see the peritoneum below. Those are the sling fibers, which is holding the indirect sac. And this is the dulux fascia, which we have to preserve over the lateral wall to avoid mesh contact to the nerves. Your lateral limit of dissection will be ASIS. Now we are dividing the transverse sling fibers so that we can reduce the indirect sac. Once you start pulling out with adequate traction on the left hand working port, you'll be able to pull out and see the cremastic fascia, which is also attaching to the sac, which has to be divided for complete reduction of the sac. Now, once the fundus is visualized, then we will begin the posterior dissection, which has been started now. Always try to splay using both the instruments and see before completing the posterior dissection, since vas might come in and you can injure the vas. You have to splay and see like this, and then dissect. What we are cutting now is the cremastic fascia. Now vas is being under vision. Avoid using cautery close to the vas, as it might transmit to the vas. Once you complete the sac dissection and patellization is done, the testicular differential fascia should be intact over the cord structures and vas difference. You're able to see till there is a few fibers attached to the sac, which has to be released. Now we are completing the medial dissection. Now we are pushing away the vas difference and dissecting the indirect sac. You're able to see the complete reduction of indirect sac has been done. In case of congenital indirect sac, you can leave the distal end of the sac and transect and loop the sac. Usually loop has been done with catgut. Either you can leave the sac intact, or you can cut and remove the distal end of the sac. Once the dissection is completed, the boundaries of dissection will be medially up to midline, laterally up to ASIs, inferiorly up to vas turning medially and the level of obturator nerve. Superiorly, it will be the arcuate level. As already Dr. Bharat sir has discussed about the indirect sac defect closure, we'll skip on that. Drain is necessary in case of a large complete sac, which has to be ideally kept 24 to 48 hours, which reduces seroma recurrence, seroma incidence. How we place the drain in our institute is, once the indirect sac is completely dissected, we will be putting a trocar from the lateral aspect. The trocar insertion will also be tunneled so that the drain will play in situ, stay in position. You can see we have tunneled the trocar so towards the indirect deep ring, and we are introducing the drain so that it will not disturb the mesh also. Finally, placement of mesh after completing the dissection. We use banana leaf technique to bring in the mesh and unfold it. It will be easy as the mesh itself goes and sits in position once you unwrap it. Ideally for direct hernias, we used to keep 12 centimeter height of mesh and 15 to 18 centimeter length of the mesh, and the mesh alignment should be positioned in such a way that it lies parallel to the iliopubic tract, covering the myopectoral orifice of Fruchar, and midline it should cross the pubic symphysis. 0.5 to 1 centimeter cross, it should be crossing the pubic symphysis. And after mesh placement, the peritoneum should be ideally 1 to 1.5 centimeter away from the mesh, so that mesh rolling will not be there while deflating the pneumo. Finally, after placing the mesh, we will suture the mesh to the Cooper's ligament using 1,0 proline. For suturing, the mesh, the needle should not be held perpendicular to the needle holder as we routinely do. It should be placed oblique As you see, we show here the tip should be away aligned away from the needle holder. Bite is taken along the corpus ligament. Then comes the final question, deflating the Nemo. While deflating the Nemo, we usually used to hold at the lower end of the mesh over the psoas muscle, so that preventing the rolling over of the mesh, which is the most common reason for recurrence. As you see, we hold it at the inferior edge of the mesh and slowly we deflate the Nemo. So ideally, TEP has a long learning curve. So demoperitoneum will be difficult to handle, and facial anatomy itself is a confusing one. Conversion to TAP is common after me. Ideally, for beginners, initially start with TAP, learn the anatomy, followed by that, which you can attempt it. Thank you. Now we will move on to the live surgery. Laparoscopic TEP first, followed by robotic TEP.
கொடுங்க. செம்ம டஃப்பாக இருக்குது.
Excuse me, sorry for the delay. We'll start the case in another 5 minutes. Just stay online.
Good afternoon, all. This is a case of a 22-year-old male presented to us with inguinal scrotal hernia. You can see the abdomen here. See, almost this is the pubis. This is the triangulation I have already told you. All the three trocars will be at the same level. That is the lateral border of the rectus, the right trocar. This is a central telescopic trocar, and the one more trocar here. So the patient is having a hernia on the right side. So I am standing on the head end of the case. So already I put the first trocar and the additional trocar has been made. I am using a 10 mm 0 degree here, clean. See, actually, you have been known the two school of thoughts, that is a midline approach and the triangulation technique approach. The midline approach, both are good approaches only for inguinal hernia repair. The only thing is the training per se. So here, what we find it as an advantage is that you can handle the both the direct, both the sides hernia, whether it is a direct or indirect, from the head and side without moving any consoles here and there. Even a larger hernias can be approached from here. The classified hernias, what I am talking about is the type 1, type 2, and type 3. These hernias also can be handled effectively by chief sir technique. Somehow he was not convinced with this midline. That's why he devised a triangulation technique based on McKernan principles. There are two schools of introducing the entry, that is a Dulac and McKernan. He followed a McKernan as his predecessor. That's why he was successful in this triangulation technique. So after putting the trocar, what you are seeing is the posterior rectus sheath and the transversalis fascia. Because the patient is very thin, you can see the space is very narrow. You can see the inferior epigastric vessel here, and you can see the posterior rectus sheath, what I am touching here. This is the transversalis fascia. The transversalis fascia is going and attaching into the midline. What I am going to do is cut the transversalis fascia, enter the midline like this. Gas எடுத்துடுமா? See, always remember, a old age persons doing a hernia is quite easy. For a young age, these fascias will be very tough. When compared to TEP and TAPP, both are good techniques in treating a hernia. The only thing is, here will not see any abdominal contents. Only we stay, that is extra peritoneally. You can see here. So once I divide the posterior rectus sheath, I have divided transversalis fascia, I have divided in the midline, so that I am gaining some space here. Gas எடுத்துடுமா? You can see the build quality of the muscle here. It is very thick. We always use a monopolar here to create the space. Sorry. கால் கிட்ட diathermy வைமா. I'm holding the scope in my hand. I'm doing the dissection here. Clean. The idea is to create the opposite side space for your left hand side trocar. You can see we cross the midline here. We are cutting the posterior rectus sheath. This is the initial crossover. Gas எடுத்துடுமா? Initial these 10-15 minutes you have to spend time to create the space. Otherwise, injury somewhere in the peritoneum will hinder your dissection. Outside view வேண்டாம். நவுருமா நவுரு. கரெக்டாக பெரிட்டோனியம் தான் வருது. பெரிட்டோனியத்தில் விழுந்துருமே. இவன் வர்றதை பார்த்தா தான் எனக்கு பயமா இருக்குது. கீழே போட்டுருங்க. The other side trocar has been made. Now we are going to move on to the target area. Clean. Because it's a young age, we can expect a difficulty in because of the complete nature of the sac in the groin. You can see the space is created. That is the space of Regius is created here. Go inside, please. You can see the transversalis fascia. Go near. You can see the inferior epigastric here. The first step is to take the inferior epigastric up. To avoid the inferior epigastric injury, take it up. So now the inferior epigastric stands on my roof. You can go medially here to expose the bone. See, now you can see the Coopers. You can see the abnormal obturator, the corona martis area. The circulation of Bendavit. That's what I told you. Never disturb these thin membranes here. So handling pneumoperitoneum is of a it's a beautiful question because the only thing which disturbs our dissection is the pneumo. When you have a pneumoperitoneum initially during these steps, what you do, take a 3 mm and just put it near the subcostal area, that is a midclavicular line on the right side here exactly, so that the gas will come out. The second thing, you can suture it, but initially the suturing will be very tough. So take a loop, or you can use energy sources like the vessel sealing, like a ligature. If you have a ligature, just take the defect and just seal it. It will seal by itself. See here, this is the indirect area. You can see the direct area. You can see the Coopers, and the dissection has been done down here. Okay, you can see the circulation of Bendavit. I mentioned, the suprapubic plexus, obturator, and the iliac will be here. So there are two ways to approach for you can see the arch here, the transversalis fascia arch. You can see a complete sac here. You always expect some difficulty here. So that's why what I do here, before entering into the space of Bogres, the space of Bogros will be approached by cutting the transversalis fascia here. Hook. You can see, make this area taut. Come out, Rajiv, little bit. You can see, cut it. You can easily enter the space. Careful, otherwise you'll injure the sac. Even if you injure the sac, don't worry. So this is the way to enter the space of Bogros. You can see here the preperitoneal pad of fat. Come out. You can see the peritoneum is lying down, and this is the fat, the preperitoneal pad of fat. Don't confuse it with the dulux fat. Dulux fat will be little bit lateral. You can see the peritoneal part of the sac here. This is the preperitoneal pad of fat. All the fat should stay laterally. This is what our idea. Merlin கொடுத்துருமா, ஹெட் டவுன் பண்ணுங்க லைட்டா. கால்க்கு டயத்ரி வைங்க. See, take the fat laterally, only catch the peritoneum. You can see, take it laterally like this. So eventually this is the space of Bogros and this is the space of Regius. So like a principle, after creating the level 1, level 2 dissection, the level 3 dissection has to be the last, whether it is a TAPP or TEP. You can see I'm taking all the fat laterally like this. You can see this is the peritoneal part of the sac. You can go inside please. So this is the sling fibers. As partially I damaged it, I just want to damage a little bit further. Gas at Turuma, come out when the gas is there. Don't go inside. See, this is the first step in dealing with the indirect. So catch the peritoneal part of the sac, take all the contents laterally. You can see this is the preperitoneal part of fat. Because the patient is very thin and young, you won't be able to see much of a fat here. But the tightness, what the sac has been holding down, is quite tough. Once you damage the sling only, the sac will come into your hand. There are two types of thought process and teaching. You can see the vas, you can see the vessels here. And the sac is going inside. It's a complete sac. It has been reduced. The sac has to be completely removed, or at least a 60% of the sac has to be removed to avoid the seroma. Some of the scenarios, the sac abandon technique. That's what you can cut the sac here itself, and you can keep the mesh. The only problem is abandoning the sac. Sometimes the patient end up in producing a hydrocele. That will be difficult to handle. Again, you have to take the patient for surgery. You can see this is the sac. I'm just holding on to the sac. You always keep in mind this area has to be bloodless always. Then only your area of dissection has to be proper. Once you cut the sling, delivering the sac will be quite easy, but in not all the scenarios. You can see the sac is open here. Because we already told you it's a congenital part of the sac. So as much of the sac we are going to harvest from here, we are going to do it. Irma. ராஜீவ் படுத்துற. ம் சரி. I think the sac has come to an end. What I'm going to do is cut off the part of the sac so that it can be delivered outside. அழுத்தக்கூடாதுமா, அழுத்தாத. ஏன்டா இப்படி காமிக்கிற? க்ளீன் பண்ணுங்க. இல்லடா, நீ இப்படி காமிக்க கூடாதுல்லடா. தொடச்சு எடுக்கணும். See, once the indirect sac has come to an end, you can see the dissection has been carried out medially. You can see the vessels here. And finally, we are going to approach the fertilization area because the sac has been taken out. You can see the vase here. My diathermy setting was almost 30. We use always a short burst. Don't try to burn it too much. And we use a energy source FT10 that comprises of everything, both monopolar and bipolar. You can see once you damage the sling fibers, additionally these things, the triangle will be formed. You can see the peritoneum here that forms the sac. We do the fertilization a little bit more, and you always try to loop it. Come out a little bit. There is a way to show. See, create a space medially to accommodate the mesh. Always preserve the fat over the iliac. Gonia. So you can see the obturator here. This is the obturator. I used to say always 3 areas you have to stop the dissection, one of which is the obturator. So immediately that is your last point of stopping. You can see here. So till the vase turns, the fertilization has to be continued. The way we have to show Rajiv from above now, no. You can see here, till the vase turns, start the dissection. Then the median umbilical ligament. You can see this is the median. You can see the medial umbilical ligament here. This is the medial umbilical ligament, and this is the obturator. So these are the three steps where you want to stop your dissection. So now we are move on to the after the fertilization. What we move on to the lateral dissection. Go a little bit lateral. As I already told you, the space is compromised here. Calculate diathermy. Sheet ஏதோ போயிருக்கு. Hook எடுத்துங்க. The best way to do the lateral dissection, because in the compromised space, patient tight ஆகுது. Patient has came out. Gas எடுத்து விடாதீங்க. 14 வைங்க pressure. So you can see, I'm just dissecting laterally up to the ASIS to accommodate a larger mesh. Separate loop ஒன்னு. Now you know, you asked me know how to handle this pneumo. இது கொடுமா loop. So this is the indirect part of the sac, peritoneal part of the sac. I'm just going to loop it here. Hold it. I'm using a catgut here. Some people used to use proline here. The catgut is comparatively cheap. and the holding capacity of the catgut, the memory, comparatively good when compared to a prolin. You can see the lateral space is also created nicely. You can see the indirect sac has been taken out. You can see the dissected area. You can see medially up to the midline and laterally up to the ASIS. This you can see the reflection portal of the peritoneum, that is almost from the indirect area, almost 7 centimeters you have to give a margin for the mesh. That's what we have created here and above. So we are planning to keep a mesh here. This area has to be divided of all those things, the tenting of the vessels to be avoided in order to keep a flat mesh. So in order to take out the pneumo, what we do, you can see clean, clean, patient tight ஆகும் பார்த்து. Now you can able to appreciate the space here. So once the pneumo is gone, after putting the 3 mm, the vessels to the vas is also preserved. That is very, very important in case of a young age. You can see this is a preperitoneal pad of fat. Don't confuse it with the dulux because this is the IPT. Below the IPT is the dulux fat here. Because the patient is very thin and young, you can't expect too much of fat here. If you want to do furthermore patellization, this is the way. Hold the vessels instead of vas. Don't hold the vas here. Just create it. I'm going to create the lateral space. Hookma. கொஞ்சம் சைஸ் சின்னது பண்ணி எடுத்துக்கலாம். So after creating the adequate space of Bogros, you can keep a mesh. Either the mesh can be a flat mesh or a 3D integrated mesh. Lateral, lateral, up, up, up. See, throughout the surgery, what I used is only a 0, not a 30 degree. And a 3D mesh. Space nalla 3D mesh. I'm creating a further more space here. Sonia. You can see the bladder here, retropubic plexus, the circulation of Bendavit. Mesh. இப்போ இது கொடுங்க மெர்லான். So this is the direct area. Because young age, we don't usually expect a direct hernia here. And you see the indirect area. You can see the completely removed sac. Part of the sac, fundus part of the sac is pertained to the cavity. You can see the fertilized portion. You can see the vessel and the vas. This is the triangle of doom. This is the triangle of doom. The main content of the vessels and nerves will be here. And lateral to this will be a triangle of pain. The almost space is dissected so far to adequate. That is days 9 steps has been completed. Here is a, even though it is a complete hernia, because of the considering age, I'm not going to keep the drain. I'm going to keep a mesh here. What I'm going to use the mesh is the 3D component of the mesh. Give it is almost 12 into 18. Hopefully clean and go. See, what I've done is when I introduce the mesh, I will never touch the mesh. Always sisters will usually change the glove, and we'll have a separate sister while doing the surgery to handle the mesh. Once the mesh is prepared, she'll be giving to us. You can see the meshes have been taken inside. We don't use this banana leaf techniques and all. So simply the dissected area, keep the mesh in the center of your dissected area, just unfold the mesh. That is more than enough. Like this, keep it in the center. The one leaf you can just adjust, just to unfold the mesh. Now the mesh is placed and the entire MPO is covered with the mesh. Always remember, after keeping the mesh, the peritoneum has to be below the mesh, like this. Pressure 14, please. Like this. The mesh has to lie flat like this. So after the dissection, after the fixation, you just keep the mesh in position to let out the gas, so that ergonomically and the designed mesh will keep in position. Okay. Now we are going to fix the mesh. Roll in, ma. Aragar, look for other theater is ready. There are two schools of thought, that are fixing and non-fixing the mesh. Even if it is a 3D mesh, we in GEM will always take a single bite here, then we'll just come out. We don't fix in multiple areas, but it depends upon the size of the hernia. When you have encountering a pantaloon type of hernia, there is a large hernias. Sometimes you may need to take a multiple stitches, avoiding the below the segment of IPT. That is the triangle of pain area. Try to avoid the sutures. So that's why I'm going to finish my surgery here. We'll move on to the next surgery, that is the robotic TEP, to be performed by Dr. Parsa, sir. Thank you.
Okay. Good evening, friends. We're going to explore the hernia, particularly thin patient, young patient, that is difficult. Uh, but since we are experienced in the disease, so even this short, some people will say it's very short umbilical tubing distance. So that is not criteria. So even if it's externally short, the peritoneum will be loose and then it will go down, so we can get a very good space. So that is the big, I can say that is the big. The short umbilical, short is the pubic umbilical distance, it is not a going dissecting means your peritoneum will go down, so you will get a space. Because we are getting a space by dissecting the peritoneum, not by lifting the abdominal wall. So that is the concept of the ETEP and STEP. So I think ETEP is good for a groin hernia, and he demonstrated nicely. And I'm going to show you today. It is the same TEP surgery in robotic, because many centers started robotic, and yeah, all of you know that Palmilisa started this step in 1996, and we learned from him, and then the entire team, and they have started doing from the long time. I can say it's almost 30 years of TEP hernias in gym. But we are doing a robo, and we could see some advantage of TEP. Even though 30 years doing one surgery is changing to robotic TEP means, imagine some advantage is there. And so I'm just dissecting, and then you can, as observer, you can see the difference. So if you see the difference, then only the success of the robotic surgery. It is not that I'm comfortable, I'm doing like this, I can see like this. So that is not a no, that will not give the future of the surgery. And by the audience, they have to convince that it looks better, it is a good one. So like that, if you think that, then it will be nice. So what I'm doing it, I'm just telling the anatomy, and then I'm doing surgery. At the end of the surgery, if any one of you you can text or the moderator can discuss the advantage, and then what the different they feel, because they are seeing already one surgery, right side hernia. I'm also going to show the right side hernia, and if you feel the difference, that then only know you can tell that robotic is better in that particular steps. Okay, so I'm going for surgery now, and you can see here wide vandrinalla. You can see patient is a little bit head down, and already I made 3 port, and many surgeons they will ask me that this creating the port is the very difficult in TEP hernia, and you are made it. So definitely already Bharat has shown how to make this 3 ports. That's why I didn't show these 3 ports. Already 3 ports is made, umbilicus on either side working, and both the instrument is above the level of arcuate line working instrument, and each instrument distance you can see here, the distance between the camera and the tape which comes to camera and the working port is 10 centimeter. So I think laparoscopic camera it will be better. I'll show it after some time with the robotic camera. So it's a 10 centimeter distance is there, and I'm using today is Versius by CMR, Cambridge Medical Robot, and this is each hand instrument is coming from the bedside unit, and I have one camera. This is the visualization unit. That's a camera unit, and you can see it is in the center. It is connected, and on either side two working instrument. So it is 2 BSU, 1 VSU, and this is a forward docking. Compare with the Da Vinci and other companies like SSI Mandra and Merrill or other Edge company. This is the direct that is a forward docking. You can like going in like a laparoscopic instrument. So in that way, when you are converting laparoscopic to robotic, this CMR is helpful. That is one of the advantage of this robo. And then suppose if you want to convert some difficult, if you convert robotic to laparoscopy, again the same port, it is like a laparoscopic port, and regular robotic surgery the ports are different. So laparoscopic, if you convert, you may require some extra port. Same port you will not be comfortable, but here you will be comfortable. So that is another advantage. Otherwise the function wise everything is same, vision is good, 3D. And this company they have a 0 degree, 30-degree up camera, 30-degree down camera. Suppose if I do ventral hernia repair or abdominal wall closer, I'm E-tip surgery for a ventral hernia, I'm using a 30 up camera. So now you can see it's a 30 down camera. You can see the light cable is up. So it is a 30 down I'm using. So all 30 up, 30 down, 0 degree, everything is available in this particular company. So this is the explanation about the robot, surgical robot by CMR. I'm going for a console now, and you can see here it is called open console. And Da Vinci has a closed console. They have to, some other companies have a closed console. Even a Edge company have a closed console, but this is the open console, and this is the hand control. And it is most of the time it is not a finger control, it is a thumb and hand control. It's a hand control. I need not to move my forearm, I have to move here. This one, if I move like this is good. And cautery is there in the fingertip. Even the foot pedal also can be connected. I'm connecting the cautery with the foot pedal because I'm very comfortable with, because laparoscopy I'm using foot pedal, same thing I'm using foot pedal. And only thing, dissection control with the hand, camera control in hand, cautery control in foot pedal I'm using it. And since it is not an active monitor, so I'm wearing this polarized glass. And this is the open console, anyone can see. By sitting behind me, they can able to see the surgery. So there is another advantage of this open console compared with closed console. Your colleagues or your younger surgeon, they get trained robo by seeing the 3D view. So that is I can say that is another advantage. Now can you change to robotic view? So now you can see I'm going to see the angle first. So our default will be 0 degree. So I'm going 30 down. And even the scaling is there. Position is medium, and the rotation is also standard. When a suturing time, I go for a fast. Instead of standard, I go for fast. Otherwise, regular time it's enough. So left hand, I'm selecting the bipolar. Right hand I'm selecting monopolar coagulation. Now you can see my right hand is active. I can rotate. You can see the external also, my hand instrument, my hand is moving. Okay. So now I'm taking my left hand. So left hand is coming, and the left hand I'm making this uh, bipolar coagulation forceps. Right hand is a Maryland forceps. Okay, since I'm this one I'm not dissecting much. When I dissecting the port, and I'm not dissecting much, so I want to show you the entire process of surgery robotically. So that's why I'm not dissecting much. So I camera control, I can move the camera close up and then wide, anything is possible. And here, what I observe is the usage of cautery. Only the midline fat I use the cautery, and most of the time I don't use cautery because midline has one vessel, midline fat. So you can go above the vessel or through the vessel, through the fat or above the fat, not below the fat. If you go below the fat, then you may enter the peritoneum. So I'm going down. Okay. Here already dissected. Part of the fat is up. You can see I have to take that fat down. Okay, I'll come later. Okay. So nowadays, what happened? I'm doing a surgery in another OT. My camera, my colleague, junior colleague will make this dissection, and then they made the port ready. So whenever I finish the surgery, I can come and operate like this. People are getting trained nowadays with the robotic docking and port for robo. So now you can see it is just I'm going down, and all the loose areolar tissue. And here I'm doing with the close-up focus. I'm doing surgery with the close-up focus.
So laparoscopically, if a surgeon, camera surgeon, if goes this much close up, then the control will be, they will get lost the control. The hand movement will be there. So that is the main advantage. You can go close up and then you can operate. You can see this layer by layer. And most of the time I'm doing with without cautery. Only whenever see the vessel, then I go for a cautery. Otherwise, I operate without cautery. So usage of amount of cautery, what we are spending to the patient is almost very less compared with the laparoscopic surgery. So these type of cobweb appearance and then loose areolar tissue, we are not seeing close up in laparoscopic surgery. We can go and operate very close to the vessel. It need not to, once you see the vessel, need not to coagulate. So because sometimes during our dissection, vessel will go away because we are seeing a multiple plane robotically. It's a very close up view, very comfortable view, and then you can sit and operate. So it is like a cave I dissected. I'm coming here. So what we are seeing down is the post layer of transversalis fascia. And initial period you will have a little bit you have to take longer time because you are this is actually all company robot is a machine. Okay, you have to how to operate this machine. All the functions are there, and you know how to utilize all the functions, no, camera control, cautery control, hand control. So if you know this, and then you can utilize this machine extensively, so you can have all the advantage of using this machine. So laparoscopically, the functions are less. Instruments is only no only you can able to hold very and camera control. Everything is with the assisting assistance control. But here the surgeon has all the control. So another advantage, your tremor is avoided. Some patient have a lot of fat. So that is a direct hernia. Still, I'm not going for a pubic bone level, so I'll do little later. So we can modify the steps, laparoscopically some step and robotically some step like. I think camera has to be cleaned. It touch some fat. Ready or extra cleaning? உங்களுக்கு எப்படி தெரியுது? Clean பண்ணுமா? Okay, clean. So once they take the camera out, so you will not move anything. So camera is out means your all the hand instrument will be freezed. Freeze means you cannot move. So that is the safety measures they are giving, because without vision something, no, if you move camera, if you move the hand, the camera, the instrument also will get moved. So that is the safety measures by all the companies. So this is the pseudo sac. Now you can see here. So I'm just taking this fat and then pushing the pseudo sac. Okay. We can have a hook, scissor, and left hand we have like another forceps is there. Each time if you change the forceps, it will take time, and your cost is also will be increased if you changing the forceps multiple time. So like that, even one instrument is enough. If you learn, you can do all the surgery with a single instrument, and except a needle, I require a needle holder for suturing. Otherwise, I can do all the dissection with this scissor only. And the laparoscopic also, scissor is my favorite instrument, and you can see such a big external pad of fat, extraperitoneal pad of fat, and or you can use a hook. A hook or a scissor is there, monopolar cautery instrument. It doesn't have a Maryland. Maryland is the bipolar. So if you have if you want to use the monopolar, you have a choice is hook and scissor. You can see the pubic bone here. Pubic bone is here. I went down very much. And suppose the prostatectomy, you can utilize this space. So this area is called corona martis area. So we are seeing very clear fiber by fiber. You can just dissect. So no, don't worry about that. So you can see the vast difference here, epigastric vessel. You can see this corona martis area. So multiple veins, no, from external iliac, external inferior epigastric, obturator. So all those things is there. So one layer is covering. I didn't disturb this layer. So I'm coming here. I'm going now laterally. See, layer by layer we can open. So we need not to disturb any other structure. You can open layer. You can see now how much thin layer I'm holding. These are all transverse facial sling fibers. This is the vast difference. Can you see how much, how many veins, how many vessels, no, surrounding the vas? I don't disturb any of this vessel, no, any of this vein, till my dissection, till my dissection. So that is the advantage of robotics. When the initial period, laparoscopic period, the people used to tell 2% of azoospermia when you are doing laparoscopic surgery, but because of the handling of vas and the vessel, and the laparoscopic experienced surgeon, no, they avoid that. But robotically, anyone can do this without injury to this vessel. Lateral போறப்ப அந்த சவுண்ட் வரக்கூடாது சிஸ்டர்.
ஆடியன்ஸ்ல இருந்த கொஸ்டின் சார், லேப்புக்கும் ரோபோக்கும் உங்களோட எக்ஸ்பீரியன்ஸ்ல டைம் டிஃபரன்ஸ்?
See, when I started, question is what is the time difference between laparoscopy and robotics? See, I am doing long time laparoscopy, so my sister, இது நீ லெஃப்ட் ஹேண்ட் நல்லா போட்ரெயின் பண்ணல சிஸ்டர், ரைட் ஹேண்ட் சாரி. See, my laparoscopic time is very, very less compared with others. So that's why average time I can say bilateral hernia, direct hernia, 1 hour or 1 hour 10 minutes will be the average time. But most of the surgeons, no, experienced surgeon, and here now this time is now I'm matching the time. And if you are doing frequently, that means your time will be lesser than laparoscopy. I can say that is because laparoscopically we have one time, that's all. More than this, some cases will be little bit less. Always other case will be the same time. But here we can have a little less time. You can robotically your time will be reducing when you are doing regularly. So that is no laparoscopically you can have some time, but after that you cannot go down. The time will be the standard, but here you can reduce your time. That is another way. And initially it was a double when I started hernia repair. Particularly many people not doing laparoscopic hernia because they are doing only TAPP. They are not doing a TEP surgery. And we are the one in GEM first started. Harish did the world's first TEP, first report by CMR, and I have done second. And since we are already very familiar with the TEP plane, so we can able to do it. So any surgeon they can do. Initially the time will be double. 1 hour surgery will take 2 hours, sometimes 2.5 hours. So your suturing is a little bit low, it will take 2.5 hours. But once you are done experience within is not no need for years together. 20 case is enough, not even a 50 case. Just 20 case, your skill will be improved, and your dissection technique will be improved, and you can reduce your time. And another thing, you can see uh, uniform layer. If you see this layer, I'm not disturbing this layer here, not disturbing here, the entire area the same layer will be maintained. So that is very well possible in robo, not lab. So that the mesh will get a very uniform fibrosis. And in laparoscopy what happened, here will be in this plane, here will be somewhere deep we went, and then here will be superficial. So each plane, each area the plane will get changed. But in robotic surgery the plane is same in everywhere. Everywhere means you can able to do this like this. So it is one of the very good thing. And here the fascia is now connecting to the spermatic fascia. Transversalis fascia connecting to spermatic fascia. So I am going in this plane only now. Even you can appreciate the plane is getting open very nicely, and whichever plane you want to go, you can go. We could see multiple level of plane, and fascia also we can able to see in a multiple level. We cannot that much no level we are not seeing laparoscopically, because it is a 2D view, and most of the time our instrument will cauterize or catch very bulk tissue we are carrying it. And then I can say it is a very fine surgery compared with laparoscopy. Robotic is a very much fine surgery. So the handling tissue, everything will be very much fine, and so that recovery is definitely faster than the laparoscopy. So this patient got a lot of fat here. Any other question? So when starting time I told you have to tell whether is robotic is good or not, because the same dissection, same anatomy you have seen by Dr. Bharat. So he is doing long time, and his TEP technique is so good, and he has shown his skill. So the same area I'm showing it in a robotic way. So you have to see the vision and dissection technique, handling the tissue. So everything is matter in surgery. So when we are starting time is okay. We finish the surgery, we keep a mess. So that is our idea. But after some time, it should be fine, no, refined. So by only robotic will give that refinement. That was I believed when I start the robotic surgery. Can you see here? I showed a vast difference previously. Clean arkaleya. Okay, clean, clean. Mm.
The time difference between the lab and robotics, sir, your
Other
experience.
face it.
Facing.
Dinesh ಒಂದು சொன்னா face it. So technique and all same. How much down we have to come from fertilization? There is no change in technique. Only thing how we are doing it. Same step how we are doing it in robo. So that is the matter. You can see no small layer. This is the visceral component of the post layer of transversalis fascia. What I'm dividing here, you can see I'm showing it in very close up view. So this is the visceral component of the post layer of trans. It is the peritoneum. So I'm cutting one thin layer below the peritoneum so that the peritoneum is getting separated from the structure. So that is the visceral component of the post layer of transversalis fascia. So these type of fine dissection, fineness, no, we can able to see because we are seeing a very close up view with a very steady camera, and then I'm seeing a 3D view. So what I'm seeing is 3D view. The same distance you are not seeing in 2D shows some little bit panoramic view, wider view, but I'm seeing the same view in a close-up manner because 3D will give a close-up view, no. So 2D will give little bit lateral view. So that's why when you are seeing a 2D, you will have some much distance between your no by seeing distance, but I'm seeing it very much closely because I'm seeing in the 3D view. So these are all the extra tissues is there. So this vessel also I can able to preserve. In laparoscopic means no, I'm just coagulating this vessel and then I'll go. That is not I go because I can my mesh will go in this plane. So now what I did, I'm just going in a different layer. You can see another plane is created. I push this layer. My mesh will go in this plane because underlying structure is very clearly seen. So need not to worry about this where to go. I went so much down. You can see I went so much down. Okay, I'll see whether it is coagulated or not. I think it's better. I used to ask my PGs because they are seeing a tip no regularly. They are assisting me now. Today, Manish is assisting. He only made these ports before I come here, and I used to ask him whether you like this robotic surgery or not. How much you feel, what you feel. It's like an open laparoscopy. So no one has feel that after seeing the surgery, I'll do better with laparoscopically. So that means your surgery is failure. Even if you finish the surgery, that means that is a failure surgery. So that is a failure robotic surgery. Patient, everyone, surgeon should feel that okay, it looks different plate, different kind of dissection. It looks better than laparoscopy. That kind of feel should come. Then only you can tell your surgery is success. Can you see? No, this is what I told. So the plane, one layer is covering the entire area from top to bottom, lateral to medial, the same plane. Can you see here? The same plane. So I'm not disturbing this plane. So the mesh is placed in this plane. What happened? The fibrosis will be uniform. It is not a very more fibrosis, adequate fibrosis. Maybe inguinal or something is postoperative pain, anything will be reduced. This much no fineness we can make it with the robotic surgery. So now I'm going laterally. Laterally means I'm working very close to the this one instrument port. How much laterally you have to go, you have to decide, and how much size mesh you are keeping. And the recommendation is 15 by 12, and usually we keep 1712 or 1812. And here also I'm following the same. I'm not using lesser small size machine robo. I'm using the same size machine robo. I'm not using a smaller size. I'm going to show you 17 by 12 or 18 by 12 today. So arm is getting strained. If you see the icon, it shows the arm is getting strained, means you have to change your the correct position பண்ணல இன்னைக்கு. இதுக்கெல்லாம் லெஃப்ட் ஹேண்ட் ஸ்ட்ரெயின் ஆகக்கூடாது. சரி, ஓகே.
சார் லேப் 3D லேப் டாவின்சி சிஎம்ஆர் இதில் எது நீங்கள் சர்ஜரி சாய்ஸ் வந்து ப்ரிஃபர் பண்ணுவீங்க?
Okay, the question is laparoscopy 4K and 3D laparoscopy and robotica Da Vinci and CMR. Okay, so it is a very wide long no very wide question. Wide in the sense both are different scenario and field. And so what happened, 3D is a good one. And what the 3D we are seeing in laparoscopy, it is a passive 3D. What I'm seeing, no, same way passive 3D, and it looks more depth. It's not a real depth. The tissue will be seen in a more depth. The surgeon will feel sometimes discomfort when you are seeing the 3D laparoscopy. But once you learn this 3D laparoscopy, what happened? Your ergonomics is better. The same port. Suppose you are doing a lap chole with the 2D 4K, and wow, how much you are getting strained. Your muscle is getting strained. The same port in the 3D, you will not get that much strain. So that is a study shows that ergonomically better 3D. So compare with laparoscopy, 3D is better. Okay, now comes 3D with robotic. I'm talking about the general robotic. Here again the vision is same like 3D camera. CMR vision, I'm talking about CMR now. CMR vision is same about the 3D vision, laparoscopic vision. But here the camera control is yours. You can get very close-up view. In 3D laparoscopy, this much close-up you cannot go. And another one is instrument control. No, it's better. It reduces all the tremor. So your instrument is steady all the time. It's very much steady. So that is the advantage of 3D robotic and 3D CMR robot 3D CMR and 3D laparoscopy, because of the steady instrument and steady camera, very much close-up focus. So these are all the difference I could say. And then compare with Da Vinci and CMR, definitely Da Vinci is better, because that is there in the field for a long time, and they have a lot of more than 2,400 patent each movement, each joints of the instrument. So many things they patented, and only 1,000 patented release 10 years over 1,000 patented is released. And so only with this 1,000 patent only other companies are started manufacturing this robotic instruments and surgical robot. So they have a restriction. They cannot copy the entire Da Vinci. It is very easy to copy the Da Vinci. And what happened when the 29 companies are started in early between in the 2000 to 2015, all over the world, 29 companies is started. All the 29 companies is closed because Da Vinci file a case against the company, so everything is closed. So now only 10 few companies is there. They are using this 100,000 patent is there. Now you can see. Can you see here? This is the gonadal vessel. This is the gonadal vessels. This is the cord structure. Can you see? I'm not disturbing any small. Can you see this? No, one or two vessel, two, three vessel. One is coming like this, and it has 3, 4 branches. Can you see this small vessel has 1, 2, 3 branches? So many things we can observe, but everything is not at all disturbed till this end. And then gonadal vessel. So how much down I'm coming? You can see. Same plane. I am in the same plane. I'm not disturbing anything. This layer is not at all disturbed. Again, same plane. You can see I'm not disturbing any layer. Down also, up also. Can you see? Here also. So this much no fine dissection is not possible laparoscopically. And this is symphysis. I went so much down, and usually 2 centimeter below this 2 centimeter from Cooper is enough. That is this dictum. But I went a little down because sometimes I used to check the operator hernia in many of my patients. If it is there, I have to go little down. So one side dissection is over. Symphysis pubis, right pubic ramus, Cooper ligament. You can see this vein, lateral external iliac vein or femoral vein here. From that it's converted to femoral. So this is the femoral canal. You can see this node. Can you see this node? So that is a node in the femoral canal. This is a femoral vein. The boundaries of the femoral canal is superiorly iliopubic tract. This is the iliopubic tract, and inferiorly pubic bone, medially pubic bone, laterally femoral vein. So this is the femoral canal. I'm coming down here. This is the corona martis, and so this is the corona martis. Corona martis, you can see multiple veins. All the layers is preserved. You can see all the small. I'm going close up. You can see all the small layers of vessels very clearly seen, and the entire layer is preserved. I'm preserving all the layers. See, the veins is not disturbed here. Only thing I'm going to coagulate here because I'm going to fix the maze. So I'm going to do something, some more here somewhere to coagulate the veins. Otherwise I cannot able to fix the maze and the Cooper's ligament. So now I'm going to, this is a vast difference. Gonadal vessel is a medial border. Gonadal vessel is a lateral border. Vast difference is a medial border. This is a triangle of doom. Triangle of doom, this is the apex, and I'm coming down. You can see reflected edge of peritoneum is the inferior border. Vas is the medial border. Gonadal vessel is the lateral border. So this is the triangle of doom, otherwise called triangle of vascular triangle. So it contains femoral artery. This is the femoral artery, and one nerve is going in this triangle, and we cannot see this now because it is covered with the fat, and some thin patients we can able to find out this now. That is a genital branch of genitofemoral nerve, and I don't need not to disturb this fascia. I don't want to disturb, so it is a genital bone nerve is there. Coming to here laterally, this is the triangle of pain. Triangle of pain, otherwise called triangle of trapezoid or the nerve triangle. Nerve triangle, since it is a 30-degree down camera, I'm not showing up. So this is the upper border is iliopubic tract, medial border is the gonadal vessel, inferiorly reflected edge of peritoneum. You can see how much I come down the peritoneum. So that is the reflected edge. So this is the triangle of pain. All the nerves is below this fat. I'm not disturbing the single small layer of the fatty covering layer. Even a very small layer I can able to hold, but I'm not disturbed. So this is a triangle of pain. So both triangle is together is called, because triangle of doom, apex is the upper level, triangle of pain, apex is lower. So both together it is called square of doom. Square of doom. And then Palnivel sir told, no, he is telling that he described one more triangle here, medial to the square of doom, that is called corona martis. It's contained corona martis. Otherwise called circle of death. And people will tell they're telling that any bleeding happen, you are not able to control. But if you are very much rough handling, you are not knowing anatomy, then only the bleeding will happen. Otherwise, no fear about this corona mortis. And since we are fixing the mesh, I'm going to coagulate some of the vessels, and then I'm going to fix the mesh. This is the anatomy I explained, and I'm going to coagulate the vessel. I'm going to fix this this one pseudosac to the bone. Then I'm keeping the mesh. So this side surgery is over. The same side I'm going to continue on the left side. I think one side is sewing is enough because same thing is continuing on the left side. And any doubt or what is their feeling? What they felt? No, how they are feeling? The difference between this laparoscopy and robotic. Now you can see this is the obliterated umbilical artery. Can you see this obliterated umbilical artery? This much big and this much clearly you cannot see laparoscopically. Laparoscopically. So you can enjoy and then you can do the surgery. And at the end of the surgery, you will be happy that you will give a very good dissection. You gave very much fine surgery to the patient. That satisfaction will be there with the robotic surgery. Can you some of you can comment on the in the text me whether you like this surgery or not, or you feel any difference between this previous laparoscopic surgery and this robotic surgery, because this will help me that whether we can sew next time live or not. No, and I can change my perception. Otherwise, the same thing will be continued. So some of your it's a freedom. You can able to text your opinion, straightforward opinion, and anything to be changed in robotic dissection. So anything, all positive and negative comment, I like it. So I want the comment from moderator and then audience. So I'm just coagulating all the vessel. I'm going to take stitch here because the pseudosoc plication to be done. For a plication, I have to coagulate the vessels with the bipolar. Any question, please pass it on to me. Okay, இப்போ வந்து இது மாத்திக்க, லென்ஸ் மாத்திக்க, லென்ஸ் மாத்திட்டு எனக்கு இது கொடு, ஹோல்டிங் போட்டு நீடில் போடு.
நைஸ், எக்ஸ்டெண்டட் எக்ஸ்பேண்டட் வியூ வந்து கேமரா ஷேக் இல்ல. எக்ஸர்சைஸ் மந்த்ரால நீங்க எதுவும் பண்ணிருக்கீங்களான்னு கேட்டிருக்கோம்.
Okay, the question is what is it? Comment.
Very nice experience with SSI.
Nice, very nicely demonstrated, sir. Do you have any experience with SSI mantra? Okay, SSI mantra, I didn't do a case live cases. I have animal training and endotrainer training, because we want to have SSI mantra both in GEM and GEM Coimbatore and GEM Chennai. And so I want I have because that time I'm using CMR. I want to go for SSI mantra. Because both OT means we can able to do tele surgery and all that. That is the idea. But a lot of disadvantage I could found out in SSI mantra. So actually it was went up to the MOE level, sign level, and then we dropped that idea. So I feel it is a little bit better. No, CMR is a little bit better in some of the situations. Still they don't have a 30-degree camera, so that is some of the disadvantages there. And that is also we can able to manage, but other movement wise I am not happy, so that's why we did that. Zero degree தான போட்ட, 30 up போட மாட்டேன், 0 போட்டாவே நல்லா தெரியும். சரி பரவாயில்ல. கேமரா கிளீனா இல்ல, கிளீன் பண்ணி போடணும். இது லெஃப்ட் ஹேண்ட் நீடில் ஹோல்டர் போடுங்க. Now you can able to see the upper side anatomy, because since 30 down means I could see all lower side. Now you can able to see the this one muscle, rectus muscle, epigastric vessel, and then the direct defect. I started initially with a 0-degree scope. I thought because laparoscopically we are using 0-degree, but robotically I feel I'm initial period now I was little bit I take very much time consuming, so I changed to 30-degree camera, so I feel very comfortable. Only for if it is an indirect sack, I dissect the sack, I keep the mesh come out. No, that is very much easier for me robotically. But direct sack means I can keep mesh now, but I want to placate the sack. So for a plication of sac, it will reduce the seroma postoperatively and then bulge. The patient will be very much happy. So I'm using a 30 up camera or 0-degree camera, so that I can able to placate. Anatomy you will be seen very nicely, and same way even a colorectal surgery, a surgery with the inside the thorax, thoracoscopic surgery, I'm feeling very much comfortable, and then very clear anatomy with the robotic. Apart from surgeon's comfort, not only surgeon's comfort will benefit, so it will be benefit to the patients in some extent. No, it is not like fully, because when surgeon is comfort, very good ergonomics, definitely the surgery will be better. That we will see in many of you seen, felt it in a laparoscopic surgery. If your port is more good, not good, you will be struggle, no. But that's why definitely the ergonomics will be helpful for a better surgery. But here it's a very good ergonomics, so definitely the surgery will be better. Another thing you are seeing in a very nice view, a very good view. So I'm going. Can you see this very big pseudo sac? Uh, Externally, I didn't show the bulge, but it was very much bulging externally, so that at the end of the surgery, immediately patient is awake, so they will see this uh, bulge. Their hand will go there to the inguinal region. If they're not able to feel the bulge, they will be happy. So this is my own technique. So you can see I take this is a 10 proline. 10 proline. I take it in a reverse way from bottom to up to the Cooper's ligament, and this is the defect. So what I do, this is like a clockwise. I started plication of the sac, with the clockwise. No, from started with the 5 o'clock. You can see I'm starting with the 5 o'clock. Starting with the 5 o'clock. I'm taking a sac. நல்லா அழுத்திக்க sister. Okay. கொஞ்சம் விட்டு லூஸ் விடு. So now I'm taking like a bursting suture, and many surgeons they are using அழுத்திக்க sister. Many surgeons they are using locking suture, V-lock, and then they fixing to the lateral border of the rectus muscle. But that is not much. That will not give much stronger when the patient strains. No, the bulge, that is a weak area. No, definitely the pressure. Pascal's law, according to Pascal's law, the pressure will be more in that area. So definitely that area, the mesh will get some more stress and strain. But here, I'm taking like a posting. I'm taking like a posting suture, and then I'm fixing it in two places. One place already I taken with the Cooper, and then same thing I can come with the Cooper again. I can come with the Cooper again. So I don't want to take very much thick because I'm taking like a posting. It's like only the sac alone is taking is enough.
சார் நம்ம மாடரேட்டர் சஞ்சய் சொன்னார் சார் லைவ்ல தான் இருக்காரு.
I think Dr. Sanjay Sonar sir is in live. And if there any comments, sir, any comment about the dissection and your experience on robotic hernia, sir? So you can see now I'm started that is starting point. No, I reach the starting point. So now what I did, I'm going back again to the Cooper. See how to identify the Cooper. So it will give some shiny appearance. Second thing, if you struggle when you are taking a stitch, that means that is not a Cooper. Your needle will get bent, or you are giving more force or struggling. That means that is not a Cooper. So I take a bursting suture, I take a Cooper's, and then bursting around the sac, around 1.5 to 2 centimeters from the edge of the sac, and then I am taking again Cooper. I am suturing. I'm going to tie a knot. Since I'm going to fix the both side, and then I'm going to fix the mesh with the same suture, the suture length will be a little bit more because I don't want to change it again. And we don't have any tactile feedback, so that is the main drawback of robotic surgery. Even whether knot is getting tightened or not, how much pressure you are giving, whether this tissue that much pressure is enough or not, so nothing you can able to see. But what you will, with the experience, you can able to tell within 4-5 cases, okay, this much pressure is enough, and need not have more pressure. Knot is
त्यांना सांग फक्त की असे केस उद्या उद्या ठेवलेली आहे, त्यांना विचार बघायचं
Hello,
आहे
I'm
का
able to hear
ती
you,
उद्या
sir. Now
डायरेक्टली बघणार.
I'm able to hear you. Hello. Now only your voice comes. I'm able to hear you now. Bulge point, sister. எடுத்து So externally the bulge is disappeared. I asked my team. இங்க வா, இது வெசல் இருக்கு பார், கொஞ்சம் வெளியிடு அத. So that is the epigastric sub branch. Scissor போடு. வெளியே வர மாட்டேங்குது பாரு சிஸ்டர், என்ன போட் ட்ரெயின் பண்ண சிஸ்டர், வெளியே வரணும்ல, நான் மூவ் பண்ணா வர மாட்டேங்குது. எடுத்துட்டு கொஞ்சம் நல்லா தள்ளி வை கூட, லேட்டர் லைன் கொஞ்சம் டிஸ்டர்ப் பண்ற மாதிரி கூட, சீக்கிரம் கொடு. அது வெசல் இருக்குது, எபிகாஸ்டிக் வெசல் இருக்குது, ரொம்ப லேட்டர்லாம் போக முடியாது. டொக்கார் அதுக்கு அடியில் விட்டுக்க. சரி போது கூட, அப்படியே கொடு. பைப்போலாரும் வர மாட்டேங்குது. epigastric vessel sister. போதும். So now why I'm asking for this lateral side port training. This is like a port training. This company has like this. The robo is assessing that okay, I'm going to work laterally. So this port training will teach the robot hand. Hey, injury ஆயிரும். கீழ பார்த்த மாதிரி வா. அப்படி வா. Okay, விட்டுரு. So now they get port training laterally. Now you can see I'm going to move the instrument very much easily. And suppose if I want to have this uh, uh, this one fascia, I can able to cut like this. So that I can go down. இது மாத்தல. கேமரா மாத்தணும்ல. 30 down போடு. So I'm going to keep a mesh now. 30 down போட்டுட்டு நீ 17-12 lens இது வாங்கிக்க. And I'm going to use a regular mesh, regular polypropylene flat mesh. And you can see everybody think that 3D mesh means you can able to place it nicely. If you go there, it will go and stuck that area. But even everything is possible with the regular flat mesh also. And initially I thought robotically mesh handling will be difficult, so that 3D mesh is helpful. So all my initial cases I go with 3D mesh. But nowadays I'm feeling that both regular mesh is also flat mesh is also fine.
Card lipoma always remove பண்ணணுமா?
Yeah, another question is lipoma cord to be removed or not. So definitely you have to remove the cord lipoma because even in a direct hernia, obese patient we could see cord lipoma. Even not in obese, some patient had a visceral fat more. Even 70 kg, 65 kg cord lipoma will be there. You have to remove the cord lipoma. Otherwise, the patient will have the feel of hernia. Each time they moving, coughing, no, that lipoma will move the inguinal canal, so it will give feel of hernia. So definitely, even if, you have to check the cord lipoma in all cases. Even in a direct hernia cases, you have to check the cord lipoma. If it is there, you have to remove. Secret fast. Time ஆச்சு.
Up and down 525 சார்.
Okay.
Up and down வந்து சேம் 30 டிகிரி யூஸ் பண்ணலாமா இல்ல செப்பரேட் ஸ்கோப்ல யூஸ் பண்ண மாட்டேன்.
Yeah, okay. It's a very good question. If it is up down 30 up 30 down, it is a different camera or not. So it is the same camera. It is the same lens. Laparoscopically we are rotating, robotically we are taking the lens, we are rotate and then we are connecting to the camera. So it is the same camera, same lens. We can keep it in 30 up or down. So now I am going to change the angle to 30 down. 30 down is already so now you can see down means how much view you can able to get it. Down view. Camera is not straight, so now I'm straighten the camera. இதையும் பண்ணிருக்கலாம் சார், left hand strain ஆகுது. So I'm going to keep the this thing a mesh. If it is difficult, then I'll go this division. Okay, this division is required or not, I'll decide little bit later. This I think something is required here. I do this. So this is the dulux fascia. What I'm dividing is dulux fascia. Always it contains vessel. Can you see this peritoneum down? And if you divide this dulux fascia, then you can have some more access laterally. I think dissected well. Even 18, 12 meshes also, I can place it in a comfortable way. But like a demonstration means I dissect a little bit more, so that mesh will go and then stay there without any wrinkling, without any difficulties. I don't want to handle much during live surgery, so I'm dissecting now. And all the structures, laparoscopy 2D anatomy and 2D view is in our mind. So when I started robo, it looks like a bigger structure. Even the cystic artery or any vessel, if I see the left gastric artery, it looks very big. Initially I told this patient had a very big vessel. But after some time, realize that okay, all the patients, it is, since we are seeing it in a very close-up focus, it is that view is there. Okay, I think I dissected well. It will accommodate even 18, 17, 18, 12 maze. I'm going to keep 17, 12 maze. ஓகே கொஞ்சம் இப்போ எடுத்துக்க கண்ட்ரோல் எடுத்துக்க இல்லை இன்ஸ்ட்ருமெண்ட் வெளியே எடுத்துரு, க்ளீன் பண்ணி போட்டு டக்குன்னு கேமரா இது இல்லை மெஸ் உள்ள கொண்டு வாங்க. It's very comfortable, very nice chair you can get, and then this handle also adjustable, monitor also adjustable, and even forward backward movement also there. Now that one question was about compare 3D laparoscopy and regular laparoscopy, CMR and Da Vinci. Da Vinci is better. Now the 5th generation Da Vinci has come, and it has had a tactile feedback sensation, and surgeon able to feel the tactile feedback. So that was not there in any of the robot. Da Vinci is the first company made this tactile feedback. But cost anyway, no, always cost is the high. And all the Da Vinci machine has this one close console. You have to go and then forward bend. You have to see, then only it will be active. That is a active monitor, immersive view. Now all others are 3D view. That is a 3D immersive view. But now they have a rotatable dome. So you can have a, you can by dome will be fixed. You have to bend. But here, according to your wish, you can rotate the dome. So that is another advantage of this 5th generation. But everything is cost. சீக்கிரம் போ. கொஞ்சம் ட்ரொக்காரு ரொம்ப லெஃப்ட்டுக்கு போகாத, மிட் லைன் பார்த்த மாதிரி போ. கேமரா ட்ரொக்கா இழுக்காத, உள்ள தள்ளணும். கொஞ்சம் மிட் லைன் பார்த்த மாதிரி. ஓகே. போறப்ப டுவர்ட்ஸ் லெஃப்ட் மாதிரி போங்க, டுவர்ட்ஸ் மிட் லைன் போங்க. ஓகே. என்னோட இன்ஸ்ட்ருமெண்ட், ரைட் ஹேண்ட் இன்ஸ்ட்ருமெண்ட் எங்க இருக்கு? Okay. Good route. You can see how much big mess. It looks big, but that is because we are seeing it very close up focus. And if it is, if I feel there is some wrinkling of the mess is there, or folding of the mess, then I will dissect laterally. So first part is you have to take this mesh lateral. You have to place the mesh laterally, then come medial.
Cooper's fixation vehicle lo பண்ணலாமா?
Yeah, Cooper fixation is done, can be done in vehicle. So usually we can do, but now our advice is because we want a good fibrosis in that particular area, so that the mesh will not get migrated. So that is the only one stitch we are making laparoscopically. One fixation of the mesh, only 1 point fixation of the mesh. So what I feel is, if you have this in a non-absorbable suture, the fibrosis will be more, and then all the time the suture will be available. Suppose you are using the taker means you are using absorbable only. No, we are not using a metal taker nowadays. So that's why absorbable also recommended. Instead of vicryl, you can use PDS monofilament, so that it is a good one. Another one is always Prolene is advisable in a mesh fixation, non-absorbable suture material. I want to take little bit of the mesh more on this side. நீ left hand adjust பண்ணி கொடுக்கவே இல்லை. மெஸ் எடுக்கிறதுக்குள்ள கொடுத்துருக்கலாம் யாராவது. So that side will be little bit dissection to be done. And can you see here, I can able to keep it the 17-12 mace without any fold. Okay. And you can see this lower border also. Can you see this peritoneum is down? Peritoneum is down, and I can able to here, even if I take the leave the gas, the peritoneum will go like this only. Okay. And down also you can see peritoneum is down, all the area. So all the lower border is checked. So I'm going for a Cooper's fixation now. The medially after dissection it will cross the midline. So already it's crossed. So there is no folding of the mesh. Wherever lecture irka, or they want to continue, they see the other side, because the same thing only I'm going to do it on other side. Just ask, just you can just send a message whether you want to see the same surgery on the other side, or we'll finish it off now. Oh, lecture முடிஞ்சதா? So I told you, no, it should not be any struggle. You can see very wide bite, and needle is not bending. Same half circle is there. I'm not struggling when I take a stitch. That means that is a Cooper. And for suturing, I could say Da Vinci is better. Needle holder is better than any other company. Everyone will very much comfort with the Da Vinci. So double off knot initially, now this single off knot. So this is a square knot. Always a square knot is holding strength is good. So initially double square, and then when you make a surgeon's knot, only this much is enough. And need not to be very much tight. Only thing our aim is to holding the mesh to the Coopers. That's all. Okay. In Da Vinci, they have a knife in the edge of the needle holder. After suturing, you can able to cut the thread with the suture needle holder itself. So that is not possible in this, because everything they patented. So they cannot, other companies, they cannot manufacturing, they cannot able to do the like the same. So I think this area, this regular flat mesh, polypropylene mesh, 17 into 12 centimeter is covering the entire area. As I told before, everything is a single plane, single layer of plane, and it is very much, coverage is good. So fibrosis will be adequate. There will not be any more fibrosis. So I'm going for the other side. For other side, we need to dock. We need to dock it again, because we are operating in a very close space. It will take another 5 minutes extra time. They will dock it, means I can operate. If you want to continue the robotic surgery, continue the robotic, I'll do. Otherwise, we'll show some videos or some discussion. We'll close the session. Moderator, and the external camera is the Kami man. பரவாயில்ல டாக் பண்ற காமிடா மாத்திட்டு இருக்காங்கல்ல. கேமரா நின்ற கேமரால தான் நிக்கணும். போய் வெளியே போய் சுத்திட்டு இருக்கிற. எங்க நின்று காமிச்சிட்டு இருக்காங்க. The same three port only. Previously it is all the thing towards the right side. Now it is going towards the இழுத்து ரைட்டா இருக்குல்ல டக்குனு சும்மா தானே இது பார் ரைட்டா. போப்பா டக்குன்னு வா உள்ள வா. கீழே பார்த்த மாதிரி வா. மேல கீழே அமுக்கு. ரொம்ப கீழே போய் குத்திராத. வந்துச்சல்ல இங்கோல் ரீஜன் பார்த்து வா. எங்க போய் மேல பார்த்த மாதிரி வா. So this will take I observe it many times. Maximum time is 6 minutes and fastest is only 5 minutes. It is not between 4 to 5. So they can able to dock it. So each side we have to spend 5 minutes extra time compared with laparoscopy. Otherwise most of the time laparoscopic and robotic time is same. இப்போ எவ்வளோ நேரம் ஆச்சு ரைட் சைடு ஆரம்பிச்சு முடிக்கிறதுக்கு? ஆரம்பிச்ச டைம் சொல்லு, இப்ப முடிச்ச டைம் சொல்லு. நோட் பண்ணி வச்சிருப்பே இல்ல? 1 hour 54 minutes-ஆ? என்ன சொல்ற? 2 hours ஆயிடுச்சா ஒரு சைடுக்கு? எவ்வளவு நேரம்னா ஒரு சைடுக்கு 45 minutes 1 hour சொல்லணும். 1 hour 54 minutes-னா என்ன அர்த்தம்? 1 hour 5 minutes. 1 hour. இப்ப டாக்கிங் 5 minutes ஆயிடுச்சு. So I took 1 hour. Mostly I finished the surgery in 1 hour. Today I took 1 hour. Maybe discussion and demonstration I took a little bit time. Usually 1 hour 10 minutes or 20 minutes for a maximum 1 hour 20 minutes for both sides. கேமரா பாரு எப்படி போட்டு வச்சு. அவங்க ஒன்றும் கன்டினியூ பண்றாங்களா என்னன்னு போடல கொஸ்டின்ல. டெக்ஸ்ட் ஏதாவது வந்துச்சா? ஒன் ஹவர் 5 minutes தான் அது 55 சொல்லிடுச்சா? So this is the hernia on the direct hernia on the left side. You can see the pseudosac. So always indirect hernia is better to be in robo. The sac dissection will be very much nice compared with direct hernia. Direct hernia means you have to plicate the sac. Indirect hernia, once you dissect the sac, most of the time we don't injure the sac when I dissecting it. So it will be easier. and the plication work, extra work is not there in indirect hernia. So I love indirect hernia by laparoscopy, the robotic. This side is also a little bit bigger defect. So the fumes is there. So I'm keeping little panoramic view because the cautery, fumes is getting disturbed my vision. So I'm keeping little bit panoramic view. Okay. So once you divide this pseudosac, separate the pseudosac, immediately the structure, what structure you're seeing is a Cooper's ligament. So this is the Cooper's ligament. So I just confirmed that whether 30 down I selected or not. Any question from the audience?
அதர் சைடும் பார்க்க கேட்டது வருதுன்னு கேட்குறேன்.
Okay. So you want to see other side? Okay, I'm just doing it. So this is a transversalis fascia posterior layer, and you can see here I'm just folding this post layer of transversalis fascia, and I'm coming here. So here there is no fear of peritoneum because I'm doing it very controlled way, and I'm just dissecting only the my cautery is going only to the one layer. Can you see this peritoneum down here? I'm going to little bit close up. I think camera light. Okay, this is the peritoneum. So this is the peritoneum, and this is the transversalis fascia. Can you see? I'm dividing only the transversalis fascia. So this I can go how much lateral I want. See, usually I do like this, and the right side I'm doing it a little bit slow because of the live surgery, and first time I want to show you in a detailed way. Otherwise, apply a little bit cartil like this, and then you can move your instrument like this, so that all the area will be fastly you can do. Okay, and then this fat to go to that side. This arm is a little bit rotated. So each layer by layer you can able to see, and then you can cut. And each layer is coming to your close to your face. So now I am coming here. The transversal is sling fibers to be divided. So can you see this peritoneum got opened? The peritoneum is going a little bit higher up here. So this is the obliterated umbilical artery. So this here. So I'm dissecting little bit more tissues. So from here you can see this white color structure. So this is the obliterated umbilical artery. This what I'm skeletinating is more. So this is the obliterated umbilical. This is the gonadal vas difference. So it is going behind this. So once this vas is turning, so you have to stop at the level. Otherwise, you will injure the bladder. See how much thick fat. So this thin layer, what I'm trying to coagulate is the post layer of visceral component of the post layer of transversalis spacer. So what I'm cutting, no, that thin layer. So this thin layer. Now you can see this fatty layer. This fat should go to the abdominal wall. This fat. Camera is getting a little bit strained. Camera கொஞ்சம் clean பண்றப்ப சுத்தி போடுங்க. Rotate ஆயிடுச்சு. Even a 18-12 miss also can be, we can able to keep it here. Can you see how much space I dissected? See this way. Down also dissected, and some more paralyzation also can be done. Okay, you can see the psoas muscle. This is the iliopsoas muscle. So I think I continue. I finished the dissection. How much time it was? Second time ஆரம்பிச்சு எவ்வளவு நேரம் ஆச்சு? 16 minutes. Okay. So now I took only 16 minutes to finish the dissection, and maybe I can coagulate this Cooper. 16-12 minutes ready வச்சுக்க. You can see how much I'm rotating and then I'm coagulating the. because one big vessel is here. This patient had a multiple vessel in the Cooper. Okay, so now இது மட்டும் மாத்து, இதுலயே பைட் எடுத்துக்கலாம். Needle holder மட்டும் மாத்து. So it took only 16 minutes time to dissect on the other side, and maybe another 10 minutes or 15 minutes I will finish the surgery. So it took only half an hour time to one side. So by bilateral means 1 hour or maximum docking time all together it will be 1 hour 15 minutes or 20 minutes. ஒருத்தர் மெஸ் கட் பண்ணி ரெடியா வைங்க 16-12. நான் முடியறப்ப ரெண்டு ரோபாட்டிக் டைம் சேர்த்து கால்குலேட் பண்ணி சொல்லணும். எனக்கு தப்பா சொல்லக்கூடாது. So how much strong, no, you can see. Can you see here? So that is the Cooper's. That's a strong. Because I'm not able to see because this is the 30 down view. When they are pressing, no, that time I can able to see. மேல அழுத்த கூடாது. Only the இதுதான். Okay. அப்படியே. So that is the pseudo sac. That is the fundus of the sac. Okay. So as I told you, I started from 5 o'clock. அழுத்திட்டு இருக்கீங்களா? அழுத்தல பார். சரி விடு. So this is my own technique, and we are publishing also. It's a so this technique, even the smaller hernia you can do, bigger hernia you can do, even a very large hernia, giant hernia, you can able to do with this technique. So that is the advantage of this technique. So I feel it's very comfortable in the smaller hernia. So if you learn this technique in a smaller hernia, you can able to tackle this bigger hernias very well. So the bigger hernia, direct hernia, is the one difficult to heal, difficult to treat compared with the indirect hernia. Because indirect hernia, this direct hernia, the pressure will be more in that area, and then it will bulge. No, the bulge will take up the mesh also. So along with the hernia, the mesh also will go outside. So that's why large direct hernia is difficult to treat laparoscopy. So வேற ஒரு சூச்சர் எடுத்துக்க. இது கொஞ்சம் டேமேஜ் ஆன மாதிரி ஆயிடுச்சு. லென்த் ஆல்சோ ஷார்ட்டா இருக்கு. நல்லா அழுத்துங்க. Scissor. டேய் எங்கடா வர்ற நீடில் ஹோல்டர் ஓ இது என்ன த்ரெட் கட் ஆயிடுச்சா போட்டிருக்கா உண்ட அது சொல்லணும்ல என்கிட்ட நான் அதுல பண்ணிருப்பேன்ல சொல்லினா எனக்கு எப்படி தெரியும் நீடில் ஹோல்டர் கொண்டு வா அது பெண்ட் பண்ணி எடுத்துக்க லேப் நீடில் ஹோல்டர் கொண்டு வா கேட்காம எதுக்கு போட்டேன் டக்குன்னு எடு ஸோ ஐ பெண்ட் த நீடில் ஓகே ஓகே போதும் த்ரெட்டை பிடிச்சிக்க நல்லா பிடி த்ரெட்டை கொஞ்சம் இரு. வந்துருச்சா ஓகே the thread needle has gone out since it is a 8 mm instrument so it is easy to take out so now application is done I'm going to fix the mesh உள்ள கொண்டு வா so it is basically teamwork compared with laparoscopy robotic should have an excellent team coordination should be there so the time will not get wasted so each work shared by our team members so that I can do in a faster way so now this is the medial you can see uncut area so that is this is the uncut mesh you can see so uncut so this will go upper medial so remaining till things will go lateral so I go lateral so always try to take the lateral one first keep the mesh laterally position the mesh laterally first then come medially so that will be easier that is both laparoscopically and robotically same you can see here the peritoneal reflection and the mesh border so it is a peritoneal distance and mesh border is a gap is there so when I leave the gas it will not lift the mesh so that is the thing you have to check and I dissected laterally more you can see some more one more centimeter mesh also I can able to keep you can see this peritoneum is here this is the peritoneum so this is the long distance is there so I kept 17-12 mesh even 18-12 also I can able to keep it comfortably so that much I dissected so lower also done so I'm going to fix it with the mesh upper bar also there is no folding okay so now I'm going to fix the mesh So again, Cooper's ligament is very well seen by its shining appearance. So you can take stitch without any difficulties. You can see without any much difficulties it is coming. And if you want, you can check the tightness also. Okay. So I try to improve my robotic time. Maybe in near future we will do it. Always any surgery, if you do it in a regular basis, so you will be have no the technique. You learn the technique, then your time will be reduced. More than the time, the perfect dissection is the very important in hernia repair. So it is not hernia. We are not removing anything. We are like a kind of reconstructing it. So I feel it is better robotic. Likewise, fundoplication also robotic. I feel it's better. That's what I demonstrated in a laprosurge conference. That is one of the very difficult case. One more than 120 kg patient weight. That's a difficult case. Also, we can manage with robotic approach. Wow. அடுத்து நீடில் ஹோல் கொண்டு வந்து நீடில் கட் பண்ணி எடுத்து கொஞ்சம் கொஞ்சம் ஓகே விட்டுட்டு பக்கத்தில் பிடி இன்னும் கொஞ்சம் பெண்ட் பண்ணலாம் ஓகே ஓகே ஹோல்ட் த த்ரெட் ஓகே ஸ்ட்ரகிள் இருந்தால் சொல்லு வேகமாக இழுக்கக்கூடாது நீடில் ஹோல்டர் கொடுக்கும் So these are all extraperitoneal pad of fat, both side. So now you can see very flat maze, no bleeding, not even no blood coming out from the main thing. And I fix it to the Cooper's ligament. Other side also you can see. Right side also I can able to see very nicely. And only thing we'll close it with some maybe handling of the needle and other things. Some blood is here. That is also not look like exact. Everybody spend the blood on it. Okay. Maybe during the time of handling it might be there. So what we do, we can have a suction here, laparoscopic suction, and then we'll have a desufflation. Usually desufflation I cannot do here. I'll leave it my team. So they remove both the instrument. They put a laparoscopic instrument. They desufflate it. Okay, because robotic instrument, when they desufflation, you cannot pull it out. Okay, so you can see here peritoneum is well down, and here it is both the extraperitoneal pad of fat is here. And tell your comment about this surgery and whether any different anatomy, not different, very fine anatomy you have seen or not. So that's what we want robotically. Huh? So the total time is the second time இப்போ வந்து left side I took over 30 minutes, right side 1 hour 5 minutes. காமிச்சிருது கேமரால காமிச்சிரு. So total 1 hour 35 minutes live surgery of bilateral tip is over. Okay, thank you so much. And I'm expecting any questions or anything. I can come out and then I can text the reply I can able to give. Thank you so much. Bye. Any question ஏதாவது வந்திருக்கா? Question வந்திருக்கா? So views so 633 views just now they're telling. So I'm so happy. More than 600 surgeon is watching. It's a great thing nowadays. And so we are showing every month. Next month is a robotic colorectal surgery. Maybe right me and AR you can able to see in robotic surgery, and all the pros and cons we will discuss. Thank you so much. Thank you. Bye.